So here that case, once again, is SFA total occlusion. Again, that problem with these nice collaterals rising directly distal to the occlusion. Usually you see a little stump here, but here not. Again, we would try to somehow preserve. And if you cannot re-enter, use a re-enter device, you would probably re-enter here, stent, collaterals are gone. So here, once again, yeah. So how do we do this? So the occlusion goes down to here. So in that case, to be able to preserve that collaterals, we pull it back a little bit, the re-enter, the GoBack catheter, and try to somehow, before the artery is open again, get it back into the true lumen. And here, yeah, so here you can see nicely the C, and you can also see some calcium, but not that bright. So in that cases, and that actually was a learning curve sometimes, not to use it in that direction, but rather then go to a direct, to move now to the C-arm position where you see 90 degrees to the former one, the needle go out of the catheter. I mean, for you, if you take the curved needle out, it should look like as if it would be straight. And if you have the impression here that is not perfect, if you have the impression the catheter is fully on the artery, on the occluded artery, on the calcium, with this direction, you avoid that minimal, the minimal movements of the needle, which may bounce away from the calcium and tend to slip around the artery on the right or on the left side. So if you have the artery and the GoBack catheter direct on their target and see the needle go out, this, as you can see here, the needle goes a little bit to the left now or to the right. You can adjust this, hold it firm, and the needle will go straight into your artery. And you cannot see this minimal movements of the needle going left or right if you use that typical position of the catheter being parallel to the artery. You could also do this with the outback, but this is something which is now actually our preferred technique. So we see the C-arm parallel to the artery, and then we go 90 degrees to this, or where we have the feeling that the artery is really on the calcium column, then we take the needle out. Of course, if you have to readjust that needle, go once again back to that to know that the needle is not going to that direction, but to the calcium, to the artery, and then go back to that position. Yeah. So here we took the needle out of the housing until we had the impression now we are within the last 2 centimeters of an occlusion. But then we went back to here once again an X-ray to see more clearly the calcium column that we are really on with the catheter on the calcium. But then we went back into the parallel version to see how the wire behaves. You can see here now it really first it had some. Yeah, we had the strong feeling here. It is going here into the total occlusion interluminally, and finally going back here right into the out of the occlusion back into the open artery. So once again, you can see here it's activated here, but the occlusion goes down to here. That's something which we try in our cases. If it doesn't work, easier than with the outback catheter, where you very often tend to, well, if it fails here, take the device out, take the catheter down, try to take the wire here to another place, take the outback back in again. You can just take the needle back in, take the wire down, and reactivate it wherever you want. So no changing from catheter wire repositioning to re-enter device back. Just take that as a crossing, as a guiding catheter, as a re-enter device, as one device.